Welcome folks. In this lecture, I will just focus on the treatment and preventive medications for acute migraine in children. I will not be touching on the types, definition and pathophysiology of migraine, which I have already covered in my previous lectures. I assume that by this time you already know about the pathophysiology types and the definition of migraine, and in this particular talk I'm going to talk about the updated management of migraine from the latest the 22nd edition of the Nelson textbook of Pediatrics, which just came out recently. So without further ado, let's get started. Now, acute migraine treatment in pediatric patients. The first thing in the treatment which is recommended by the Nelson textbook is the non-steroidal anti-inflammatory drugs and paracetamol. Now, for children experiencing migraine attacks, the NSAIDs, that's the non-steroidal anti-inflammatory drugs, are a primary treatment option. Ibuprofen is particularly recommended, and it's effective at a dosage which you can start at 7.5 and you can go up to 10 milligram per kg per dose, administered as soon as the symptoms begin. This is very important. As soon as the symptoms begin, the non-steroidal anti-inflammatory drug ibuprofen has to be started. 7.5 to 10 milligram per kg per dose. Now, children who cannot take non-steroidal anti-inflammatory drugs, then paracetamol is an alternative. And again, the paracetamol dose in migraine is 15 milligram per kg body weight. Not 10 but 15 milligram per kg body weight. Now, it's also crucial for children to understand the importance of early symptom reporting, especially in settings like school, to ensure that timely medication administration is given to them. It is also important to limit the use of these medications, paracetamol or non-steroidal anti-inflammatory medications, to prevent the what we call as the medication overuse headaches. Because we recommend that no more than 2 to 3 uses of these medications should be done per week. If they need more than this, like 2 to 3 doses per week, then either they have to rely on hydration alone for the rest of that week, or then they have to add triptan. So if non-steroidal anti-inflammatory drugs are not working, they have already taken maximum dose, and either they have to stop there, just continue with hydration, or the second option, and step 2, is to add triptans. Remember, and I will go into what triptans are and how they are given. Another option, apart from non-steroidal anti-inflammatory drugs and paracetamol, is aspirin. Aspirin can be considered, especially if the child is above 16 years of age, but we do not recommend aspirin to be given below 16 years of age, obviously because of the association with Reye's syndrome. But if the child is more than 16 years, you can consider aspirin as well. Now, coming down to triptans. So if the NSAIDs are not effective, then you have to use triptans. So triptans for severe cases can be given. Now, in severe migraine, where you think that the non-steroidal anti-inflammatory drugs are not working, you can give triptans. Now, the Food and Drug Administration in USA has approved several triptans for pediatric use, and I will go through them. I think probably there are 3 or 4. So the first one is elmotriptan. So elmotriptan can be used in children like who are aged 12 to 17 years of age. The other one which can be used in even in younger children is rizatriptan. So rizatriptan can be used from 6 years onward. Remember, most of these triptans are used 12 years and above, but rizatriptan is one medication which you can use in children as young as 6 years of age. Then we have got zolmitriptan. Zolmitriptan can be given to children 12 years and older, and the good thing is that it comes in nasal spray, so the administration is quite easy. It's usually given in the form of a nasal spray. So zolmitriptan. And the fourth one is sumatriptan. Again, most of these are given 12 years and above, except rizatriptan, which can be given in 6 years and older children. Now, triptans are very effective medications. They provide rapid relief, and they are generally well tolerated. But as I told you, that there are intranasal options available for zolmitriptan as well. It is quite beneficial with those who have got, let's say, nausea, or some of them, especially an intranasal option is also good for those who have got difficulty swallowing pills. Now, again, as far as these 4 triptans are concerned, they have varying, sort of onsets, varying half-lives, and they are given in different dosages. But again, it depends on your hospital policy. You can use any one of these triptans for severe migraine. Now, the third thing is combination therapies and some other formulations. Now, remember, for comprehensive migraine management, you can combine non-steroidal anti-inflammatories with triptan. So it's not like that you have to wait for the NSAIDs to kick in. Sometimes, so you can combine these medications and they can be very effective, especially if you combine naproxen with sumatriptan. So naproxen is another non-steroidal anti-inflammatory medication, and that can be combined with sumatriptan. But remember, the dosing adjustments are important for children less than 40 kilograms of weight. And obviously some options like nasal spray can be useful for children who are unable to take oral medications because of nausea or vomiting. But it's also very important that you keep them proper hydrated. Proper hydration is very, very, very important during acute migraine attacks, because it's like it's important because it would mitigate the vascular constriction side effects commonly seen with triptans. So if they can tolerate oral hydration, if the children are not vomiting, then the Nelson textbook of pediatric recommends sports drinks. So instead of plain water, sports drinks like glucosides are preferred. Okay. Then the fourth thing is in adjuvant therapy is anti-emetics. Now, in cases of severe nausea and vomiting, anti-emetics like prochlorperazine and metoclopramide, though I personally recommend prochlorperazine because metoclopramide has got a very bad side effects profile. So prochlorperazine is recommended because of its dopamine antagonism, which is very effective against migraine associated symptoms. Now, usually prochlorperazine, or even if you are using metoclopramide, they are administered intravenously. Why? Because for quick relief. Remember, they are not effective orally in migraine. They are not that much effective orally in migraine, so they have to be used intravenously. Remember, intravenously. So prochlorperazine can be given. Metoclopramide can be given again intravenously. For extremely resistant cases, remember, you can also use dihydroergotamine, which is a very strong vasoconstrictor, but this is only given in inpatients. Nelson textbook does not recommend the outpatient use of dihydroergotamine. It has to be, if you have to consider that, then the patient has to be admitted and has to be given under close observation, like in under medical supervision. And now coming to emergency department treatments for intractable migraines. Now, there are many times when you come across conditions which are intractable migraines. I mean, you can't even track them back, like, whoa, what's happening? But again, the child is in such a bad condition, or the headache is so much bothering him, they ultimately land in emergency departments. So in that, the first thing that you can consider is antidopaminergic medications in emergency departments. In severe migraine, antidopaminergic drugs like as I told you earlier, prochlorperazine and metoclopramide are crucial. So again, as I told you earlier as well, they are very effective if they are given intravenously, not orally but intravenously, and they offer significant improvement, and these children can be headache free within hours if you give these medications. Now, typically the dose for prochlorperazine is 0.15 milligram per kg body weight, 0.15 milligram per kg body weight with a maximum of 10 milligram. Should never go above 10 milligram because then the side effect profile is increased. So with a maximum of 10 milligram, but usually 0.15 milligram per kg, it can abort attacks effectively and is preferable to metoclopramide. Remember, prochlorperazine is preferable to metoclopramide according to Nelson textbook of pediatrics. Again, which has got a similar dosage. Metoclopramide has also got a similar dosage, but it may be less effective. So prochlorperazine is more effective when compared to metoclopramide. These medications are also notorious to cause extrapyramidal symptoms, particularly in children. But if you are worried about that, then these can be managed with intravenous diphenhydramine. In case if it occurs, you can give these children what? IV diphenhydramine. So remember, you can give IV prochlorperazine 0.15 milligram per kg body weight to a maximum of 10 milligram. And in case if there are extrapyramidal side effects, then you can give them IV what? Diphenhydramine. Okay. Also in emergency departments, obviously, because you've got the liberty of putting an IV line in and give you IV medication. So that's why in ED departments, it's better that you give them IV prochlorperazine. You can also give them non-steroidal anti-inflammatory medications. You can give them orally, or you can give them some of them can be given IV as well. Now, ketorolac is one medication which is frequently used in emergency settings, either as a monotherapy, as a single drug, or combined with other medications like prochlorperazine. Now, if you are given if you're giving ketorolac as a standalone treatment, it shows a response rate about 55.2% according to Nelson textbook of pediatrics. But research has also proven that if you combine ketorolac with prochlorperazine, if you are giving both these IV, the efficacy increases dramatically to 93%. So 93% of your kids would be, sort of responding to the good effects of these medications. So prochlorperazine, if combined with ketorolac, the response jumps to 93%, while alone with ketorolac it is almost like 55%. Then the second class of medications which you can consider in emergency departments are anti-epileptic medications. Yes, anti-epileptic medications. Now, in those anti-epileptic medications, sodium valproate. Now, sodium valproate, which is an anti-epileptic medication, is traditionally used for migraine prophylaxis, but can also be used in acute settings. Again, according to Nelson textbook of pediatrics, if you have to use it like in an acute setting, it is given IV in a dose of 15 to 20 milligram per kg body weight. So if you give it IV in this dose, 15 to 20 milligram, it can quickly reduce the migraine symptoms. Now, if once you have given the initial dose, the IV, then an oral regimen can be given to prevent reoccurrences. And despite the benefits of sodium valproate, it's also important to monitor for potential hypotension during IV administration. Remember, it can cause if IV medication of this sodium valproate can cause hypotension. So it's important that you also ensure adequate hydration by giving them IV fluids. Then triptans in acute ED settings. Obviously, if somebody can tolerate orally, you can give them 50 milligram of oral sumatriptan, but subcutaneous sumatriptan is another option for acute relief, which shows like 72% efficacy within 30 minutes and 78% efficacy at 2 hours after administration. Now, given the short duration of migraines in children, the 6% recurrence rate which can happen is considered appropriate. However, care must be taken regarding contraindications, particularly with recent use of ergotamine or any monoamine oxidase inhibitors, as well as the potential interactions leading to serotonin in syndrome in patients on SSRI, especially those who are taking antidepressants. Then you have to be very careful while administering triptans in these patients. Remember, very important point, triptan, sumatriptan, whatever you are given, are contraindicated in hemiplegic migraine. They are always contraindicated in hemiplegic migraine, and this you should always keep in your mind. Remember. Now coming to preventive therapy for pediatric migraine. It's important that once you have treated the acute attacks, if the children have got a history of presenting again and again, they have to be put on some preventive therapy, like sort of a prophylaxis. So the first class of medications which we use for prophylaxis of pediatric migraines are calcium channel blockers and another class of medication known as antidepressants. So in calcium channel blocker, flunarizine is a calcium channel blocker. It is very effective in migraine prophylaxis. It can be given in a dose of 5 milligram daily, according to Nelson textbook of pediatric latest edition, and you can increase the dose to 10 milligram after 1 month. So you start at 5 milligram orally, OD per day, and you give it for 1 month. After 1 month, you increase the dose to 10 milligram, and you can give in between. You can give some periodic breaks as well. In antidepressant, amitriptyline is another option which is commonly prescribed at a gradual dosage increase to 1 milligram per kg, body weight, given daily. Especially they have to take in the evening because of its side effects of sedation. So amitriptyline, you can give it and you can increase the dose up to 1 milligram per kg per day. Usually this takes a couple of weeks to kick it in action, but they are very effective medications in preventing the acute attacks of migraine. Then the next class of medications to be used in prophylaxis of migraine are your anti-epileptic medications. Now, several anti-epileptics are used for migraine preventions. First one is topiramate. So topiramate is usually used in teenagers. It's effective in doses of 50 to 100 milligram, which is given twice daily, with care to increase the dosage slowly to mitigate the cognitive side effects. So topiramate is one medication, 50 to 100 milligram BD. Then we can also use sodium valproate, which is usually given in a dose of 10 milligram per kg twice daily. Again, we have to monitor for side effects like weight gain and liver function changes. So every 3 to 4 months, LFTs have to be done. Other anti-epileptics like levetiracetam, Keppra, and gabapentin are also considered, but they have less specific dosage guidelines in pediatric populations. So by and large, the most important anti-epileptic medications which are used in migraine prophylaxis are topiramate 50 to 100 milligram BD, or sodium valproate in the dose of 10 milligram per kg body weight given BD, again with monitoring for liver function test every now and then. Then the other class is beta blockers. So beta blockers, propranolol is an old beta blocker. It has shown positive results in preventing pediatric migraines, particularly in some subtypes like basilar type migraine associated with postural orthostatic tachycardia syndrome, POT syndrome. Now the typical dosages and contraindications are especially contraindications are asthma and depression. So remember, propranolol can be given, which is a beta blocker for prophylaxis of migraine. Another medication which can be given in young children, those who are less than 10 years of age, even in very young children, is cyproheptadine. Cyproheptadine is an antihistaminic, and the dose is 0.1 to 0.2 milligram per kg BD. So 0.1 to 0.2 milligram per kilogram body weight. Again, this can be given BD. This is very beneficial before puberty because of its appetite stimulating effects as well. So especially if those kids who are not eating well, if you give them cyproheptadine, not only it helps in their migraine prophylaxis, it also stimulates their appetite and they start eating. So in Asian countries, this medication is also used as an appetite stimulant, but it's an antihistamine and is very effective in migraine prophylaxis for young children, very young children. So remember, Nelson textbook recommends cyproheptadine as the first migraine prophylaxis in very young children, again because of its appetite stimulating effects as well. Then we have got the very interesting group of nutraceuticals which are used in migraine prophylaxis. So some of the natural supplements like riboflavin and coenzyme Q10 are used in varying dosages. So riboflavin in a dose of 25 to 400 milligram daily and 1 to 2 milligram per kg per day for coenzyme Q10. These are favored for their minimal side effects and natural origins, though the effectiveness in children is less documented as compared to adults, but there has been sort of an interest in use of these nutraceuticals, riboflavin and coenzyme Q10 in migraine prophylaxis, and in certain cases it does work. So there is no harm in using these medications because they are natural supplements and they are not licensed class medications which require a prescription, but research has shown that in certain cases they can be very effective in migraine prophylaxis. Then there has been some research about the botulinum toxin. So ONA botulinum toxin A can be used for chronic migraine cases. It is used off-label in pediatric settings, especially at dosages ranging from 75 to 200 units. Now some studies indicate improvements in headache frequency and disability scores, transforming chronic daily headaches into intermittent patterns in many patients. So they say that there has been some good effects because of ONA botulinum toxin A. So this can be used in certain cases according to Nelson textbook of Pediatrics. These preventive treatments aim to reduce migraine frequency and intensity while considering the unique developmental and health profile of pediatric patients, which are unlike the adult patients. So my friend, this was a summary of the treatments and prevention of pediatric migraine according to the latest 22nd edition of the Nelson textbook of Pediatrics, which I consider to be the most knowledgeable body of text for contemporary general pediatrics. If you have liked this video, give me a thumbs up, and if you've got any question, put it down in the comment section below. Share it with your friends, and if you haven't subscribed to my channel, what are you waiting for? Subscribe, okay? It helps. Thank you very much. Have a good day. Bye-bye.